of Medicine. And we're pleased to welcome you all here today. Our program today is entitled The Ash and the Fire, Writing About Medicine, the Body, and the Mind. It features Dr. Christine Montross from Brown University's Warren Alpert School of Medicine in Providence, Rhode Island. We're really delighted to have her here. It's especially satisfying to welcome her to Charlottesville on something of a blue sky day that's just hinting at autumn. She was originally scheduled to speak here last January, until one of last winter's nuisance Atlantic coast snowstorms brought just enough of the white stuff to disrupt air travel and also to close UVA. So in rescheduling for this week, I promised her no blizzard in September, and it looks like we made good on that, which is good. Being a physician, a psychiatrist, and a writer is something that Christine Montross does extremely well. In both domains, she traffics in words, be they patients' stories, or her own musings on the mind and the human costs of mental illness, or the dialogue between physician and patient in which words and simple presence seek understanding between two worlds. Remarkable intelligence, sensitivity, and insight run beneath and inform her worlds and her words. If you read her books, you'll discover a doctor of breathtaking curiosity and great compassion. Through her, you'll encounter persons with mental illness whose suffering she seeks to allay. You'll also find a thoughtful woman who loves very much what she does and who is grounded in both her work and in her family. She's written 2 books, both of which have been highly praised in medical circles and in the public square. Her first book, Body of Work, for medical students in our audience, is something like the first-year anatomy reflection project writ large. This does not necessarily set the standard for what you have to do. But it's an eloquent exploration of medical school and mortality prompted by the human cadaver dissection experience. Her new book is Falling into the Fire, and there she discusses how diving deeply into her most challenging patient encounters has led her to the ancient concept of abiding as a lost tenet of patient care. In this hour with us, she'll also speak in defense of repugnance, encouraging clinicians, apprentices, as well as those long practiced, to acknowledge rather than suppress the discomforts which naturally arise in working with patients. Dr. Montross has filed the requisite conflict of interest forms, and she had no financial conflicts of interest to disclose. And so with no further delay, please join me in welcoming Christine Montross.
Thank you. Thanks, Marcia, for that very kind and lovely introduction, and also for bringing me here. I'm happy to be here. It's my first trip ever to Charlottesville, so I'm enjoying myself and enjoying getting a glimpse of the campus and the folks within it. So thank you for your warm welcome. I had dinner last night, which was a treat, with some students who are part of the Hook Scholars Program, and that was just a wonderful thing to learn about, and a wonderful human being to learn about too, and learning about Dr. Hook and the tradition that he established here. So I'm very honored to be a part of this esteemed lecture series, and also connected in some small way with that legacy here. I was chuckling a little bit as I was getting mic'd up because I have 2 young children at home. In fact, my daughter, who's 8 going on 16, will frequently say to me something like, I just don't understand why people want to come here and you talk. That's always amazing. But my son, who's very into Star Wars and droids and everything, I thought he would have taken particular pleasure in the fact that I've got stuff hooked up to me and all behind me. And that he was R2-D2 for Halloween last year, and I made him this costume that I was very proud of, with like a painted mixing bowl on his head and a brown laundry basket. And he said, Mama, I can't wait for the most important part. And I said, what's that? And he said, the doors that fly open and the planes that fly out. And I thought, the great thing is that's your imaginary part of the costume. So anyway, But it's a pleasure to be here. And Marsha's exactly right. This is this book and what I'll be reading from and talking a bit about today. It comes from the psychiatric encounters that really gnawed at me after I went home. And those of us who practice medicine or are learning to have all had that experience of going home and having patient encounters that we just can't shake. And for me, that's really an impetus for writing, and that's from whence these stories came. So I'm going to read a little and talk a little, and then we're going to leave some time for questions at the end. And then I'm delighted to sign books and chat outside afterwards. I do have a very quick flight plan afterwards, so I can't stay too terribly long, but I will look forward to that chance to talk as well. So I'm going to read first from a chapter called The Woman Who Needed a Zipper, and this comes very much into that theme of repugnance that Marsha talked about. Lauren's back again, the gastroenterology fellow groaned. Light bulbs this time. I had no idea who the fellow was talking about. When I told him so, he began to laugh. Oh my God, you've never seen Lauren? Every time she comes in, the ER docs call us and we call you guys. We all give our advice on how to treat her, but you know what she really needs? I didn't. A zipper, he said. See you in the ER. I was utterly confused. Light bulbs? A zipper? Sounded more like supplies for a child's science project than relevant clinical information. My mind was spinning as I walked through the dingy hospital stairwell to the emergency room to meet Lauren. She was in a room across from the nurses' station. The ER rooms had 3 walls. The 4th wall was a pink and tan curtain that could be drawn for privacy or pulled back to enter or exit. Lauren's curtain was wide open, and a security guard in a navy uniform sat in a plastic chair at the foot of her bed. I took a look in as I walked by. Given the gastroenterology fellow's dramatic reaction to her presence, I expected her appearance to be notable. It wasn't. She was sitting glumly on the bed, upright in a hospital Johnny. She was thin. Her dirty blonde hair was a little mussed. She was 25, but she looked slightly older. Otherwise, there was not much about her that was remarkable. I continued walking by. I wanted to take a look at her chart before I went in. As I pulled Lauren's chart from the nurse's station, one of the nurses seated there glanced at my name tag. Christine Montross, MD, it read, psychiatry. Aha, the nurse smiled, and in a sing-song voice added, I know who you're here to see. The woman in 2B, I asked, you know her? The nurse nodded and laughed, surprised. You don't? I thought everybody knew Lauren. Have fun. She winked and handed me a folder with the patient's ER paperwork in it. Oh, Doc, she called as I walked away. Don't lend her that nice pen of yours. I opened the chart. A sheet of Lauren's orders was on top, along with the ticked boxes indicating the conventional laboratory studies for ER patients were a few additional specifications. Finger food diet only, read one line. Beneath it, no objects left in room, see behavioral care plan. I couldn't be sure how to interpret these orders, but from them I surmised that Lauren must be either suicidal or homicidal. Patients who were relegated to finger food diets were those who could not be trusted with utensils. Beneath the orders page was a sheet of Lauren's lab values. I quickly scanned it, looking for the typical irregularities of psychiatric patients: elevated blood alcohol levels, a positive drug test, subtherapeutic medication levels, thyroid abnormalities, infections. With the exception of a toxicology screen that was positive for her having smoked marijuana sometime recently, nothing stood out. Her complete blood count and electrolytes were totally normal. Her pregnancy test was negative. Chest and abdominal x-rays had been taken. The results were pending. I flipped through the remainder of the paperwork and found that Lauren was already slated for admission to a bed on the internal medicine service. The admitting resident had seen her and written a note. I deciphered the scrawled shorthand to read, "This patient is a well-known 25-year-old female with extensive psych history and multiple previous intentional ingestions." Usually, an intentional ingestion meant that someone had drunk bleach or eaten rat poison or overdosed on pills as a suicide attempt, but the meaning was different here. Light bulbs. Suddenly, keeping utensils and objects and nice pens out of Lauren's reach made sense. Nobody wanted her to swallow them. I walked past the security guard and into Lauren's room. Before I could introduce myself, she glared at me and said, "Let me guess, you're the shrink, right? I can always tell you guys, you're all nicey nice handshakes and dipshit smiles." The security guard, who had doubtless seen a number of ER psych consults, stifled a chuckle and put his fist over his mouth to hide a grin. "Sounds like you've pegged us," I answered, reaching out my right hand in a nicey nice shake. "I'm Dr. Montross." "Yeah," replied Lauren, glowering at my hand without taking it. "I can read your name tag, Christine, but unless you're going to get me something for this pain, I'm not in the mood for a conversation." I turned to the security guard. "Would you mind letting us talk alone for a minute?" I asked. "Whatever you say, Doc," he shrugged. "I'll be right outside if you need me." He stepped out and drew the curtain closed behind him when he left. I slid his chair to the side of Lauren's bed and sat down. Lauren pulled the hospital blanket up to her neck, lay down against her pillow, and rolled onto her side, turning her back to me. "Jesus, you people don't listen. I wasn't kidding. Unless you give me something for my pain, I'm not talking. Since I'm meeting you for the first time, it's hard for me to know about your pain. If you tell me about it, maybe we can come up with a way that I can be of help." I offered. It was a stretch. She was talking physical pain, and I was going to try to access her psychic pain, but it didn't feel like a lie. I knew I wasn't going to write her an order for pain medication. That was the territory of the ER and the medicine teams, but I needed an entree, and I hoped that asking about her pain would soften her defensive stance, or at least encourage her to roll over and look at me. "What's going on that you've ended up in the emergency room?" "Read the chart," Lauren intoned, not making a move. "I've looked at it a bit already," I said, "but I'd actually rather hear from you." "Well, I'd rather be left alone," she interrupted. "Fair enough," I said. "Let me just read you what I've got here, and you tell me whether that sounds about right, okay?" I opened the chart to the admission note. Lauren was silent. "It says here that you were feeling upset, and you swallowed some pieces of a light bulb. Is that right?" Lauren scoffed, then abruptly turned toward me, angry. "Yeah, upset. That's one way to put it. See, that's why I don't talk to you people. I'm in the hospital 3 days ago. You all decide, you shrinks and the surgeons and the GI docs, you all decide to kick me out even though I'm telling everybody I'm not ready to go home. And then some intern writes that I'm upset. Well, yeah, I'm upset. I'm upset because I told you I wasn't ready to go home, and no one listened to me. So pardon me if I don't really buy that you're so interested in my side of things." "What happened with the light bulb?" I asked. "Light bulbs," she said. "Okay, what happened with the light bulbs?" I was pissed. "I crushed them up and swallowed them," she said matter-of-factly. "Not the metal part, just the glass and wire." I nodded. There was a moment of quiet between us. Then she spoke. "Now do you believe me that my stomach hurts?" I left Lauren and pulled her old charts from medical records. She had stacks of them, some of which were more than 4 years old and so had been archived. I looked up the most recent admissions that had taken place in the last 4 years. There were 23. So her admissions, which happened, as you can tell with some frequency, were prompted by the ingestion of a kind of startling list of things, which included screwdrivers and bed springs and barbecue skewers, pieces of curtain rod, drill bits, all kinds of things. Over and over, Lauren would swallow potentially dangerous objects in the context of stress. She swallowed a screwdriver, knife blade, and ninja knife when she learned that her uncle was terminally ill, 2 knife blades and 4 fork handles in response to learning that her sister had hepatitis, a box of nails after a fight with a neighbor. Each time she said she felt better after she had swallowed something and then brought herself to the emergency room for treatment. Over and over, doctors performed endoscopies, threading a camera and tools down Lauren's throat with a tube to try to get the objects out before the things she had swallowed inflicted damage on her esophagus, stomach, or intestines. Only once, after she'd ingested a single spoon handle, was endoscopy deemed unnecessary. She had some discomfort, the discharge summary read, but the spoon passed normally. In contrast, once when an 8-inch knife blade was too dangerous to pull back up through her esophagus and out of her mouth, Lauren's abdomen had to be surgically opened and the knife removed. Not infrequently, once awake and recovering back on the floor, Lauren would swallow something in her hospital room and require further treatment. Several times she swallowed the handles of spoons from her meal trays, once a pencil. Once she broke fragments of wood from the frame of her room's window and ate them. One night in the emergency room, she removed and swallowed a metal piece of the gurney. So over the course of her treatment, I think as many of us have probably seen, these patients, particularly self-injurious patients, cause great frustration in the clinical staff that tries to treat them. And the frustration manifests itself in many different ways. Sometimes it manifests itself in hostility toward the patient. Sometimes it manifests itself in fighting in between the teams who are trying to discharge responsibility for these patients who are very frustrating. But I spent a lot of time talking in the chapter about how I think a great deal of that comes from the sense of helplessness that we feel, that we are charged with the task of making people better, and people who harm themselves fly in the very face of that impulse and that intention. So I'm going to read another section here that talks a little bit about that helplessness on a systems level. So as I prepared for Lauren's imminent discharge, so a lot has happened between last message and this message, I threw myself into creating an aftercare plan for her that would be more than a formality, one that actually had a chance of helping her break this cycle of admission after admission. Without insurance or money to self-pay for her treatment, Lauren did not have the option of seeing a psychiatrist, a private psychiatrist or psychotherapist. If she did, she might have been seen by a therapist every week for an hour and a psychiatrist once or twice a month. Instead, Lauren was treated by an overextended, publicly funded mental health center where she was scheduled to see a psychiatrist for 20 minutes 4 times a year. Of course, in one of the ironies that are all too common in a country with healthcare discrepancies, a single hospital admission for Lauren, paid by the taxpayer-funded state medical assistance program, cost more than a year of private outpatient care would. I called the psychiatrist at the mental health center to whom Lauren was assigned and learned from him that one of the center's only other psychiatrists had recently quit. With an ever-increasing caseload and an ever-shrinking budget, he said there was no chance of her being seen more frequently. I had him transfer me to Lauren's case manager to inquire if she could at least be seen by him more regularly. Lauren didn't keep her appointments, the case manager told me. True, he said, she had no car and lived miles outside the bus route. Look, he paused, there's only so much I can do. I can't help her if she doesn't come in. I asked about the center's mobile treatment team that goes to patients' homes, takes them their medication, drives them to their appointments. I guess it's possible, the case manager said. She'd have to be evaluated by them. Let me check the book. I waited on hold for several minutes. I was disconnected. I called back. Oh, hey, the case manager said. Yeah, I can book her for an appointment for a mobile treatment team eval. Our first available opening is June 23rd. It was now February. We were talking a bit last night about why I love my job as an inpatient psychiatrist, and one of the things I love about it is that patients often come to us in these larger-than-life states, and it really lays bare the capacity of the mind to reach into these far peripheries of the human experience. So the next section that I'm going to read is from a chapter called Your Drugs Take Away the Love. And it's about a young man who came in a bit of a larger-than-life state and what kinds of challenges that raises for us as clinicians. Speaking of larger-than-life people, I recently saw Patti Smith, the godmother of punk, give a reading, and as I'm looking down at these Post-it notes, she also had her book, Just Kids, which is a beautiful National Book Award-winning book, and she came out and she had her guitar slung over one shoulder, and she had this book with all these Post-it notes, and I thought, I have a book with Post-it notes. I love Patti Smith, and I long to identify with her in many ways, because I just think she's incredible, but as she read, she would take the Post-it notes off and she would crumple them up and toss them on the floor. And I thought, I don't know how that'd go over at medical center after. That's the end of that chapter. So I have a little bit of that urge in this larger-than-life chapter, but I'm going to try and keep it in. Yeah, Marcia says okay. All right, so this is about a 23-year-old young man who was brought in after his girlfriend raised some concerns that he was behaving in a bizarre way. He was walking backward, walking in a circle before picking items up. He said that he was sleeping without sleeping. He was urinating in a Coke bottle. He was having trouble expressing his thoughts. And his parents actually flew in from another state after they were called by him. And they sort of believed he was having a spiritual awakening, but they agreed that his behavior was concerning. So I'm going to read a little bit about that interaction. The medical student I was working with walked into the evaluation room and gestured for Colin, this young man, to follow. He did and stared at me, then stared with the same intensity at the empty chair to my left, then at the locked window with no shade, and finally at the Monet poster encased in plastic and bolted to the wall. When asked to, he sat and smiled. Hi, Colin, I'm Dr. Montross, I said, and you've already met VJ, the medical student on our team. If it's okay with you, I'm going to let VJ start, and then I might pipe in at the end with a few more questions. How does that sound? Sure, replied Colin, and then to VJ he said, welcome. I could tell the student wasn't exactly sure how to respond. Thanks, VJ stammered. Why don't we start by hearing why it is that you came to the hospital? Colin sat quietly for what was probably a minute that seemed like much more. Then, right when I was on the verge of repeating VJ's question, the silence broke. I'm having trouble communicating my life journey to others, Colin said. Tell me what you mean by that, VJ asked, leaning forward in his chair. Well, Colin responded, smiling, I think you know this. VJ smiled back, perplexed, then shrugged. Colin continued, the most important thing for all of us is to know that life is joy. I'm experiencing a soulful happiness, and I think it's hard for everyone to comprehend. As the interview went on, I jotted my own rough clinical assessment for the file. Wide-eyed, malodorous young man in tunic, unshaven. Speech is slow. Thought process is disorganized and circumstantial. Content is grandiose. Patient denies auditory or visual hallucinations, but does endorse elated mood. Affect is expansive. Insight and judgment are poor, as evidenced by the fact the patient does not see the need for help. VJ finished gathering some final information. Colin had graduated from a prestigious college with an art degree. His senior thesis had been a series of huge metal sculptures. Since college, he had been employed on and off as a metal worker on construction sites to support his artwork. He had recently quit to spend a month following a woman called Amma, the hugging saint, through the western mountains of the United States. Amma's doctrine is love, he told me. She feels love for all people, and she provides comfort to those who suffer by hugging and blessing them. During the time he was with Amma, Colin had smoked pot and used some hallucinogens, but he said there had been no drug use for a month or more, and his clean toxicology screen from admission supported this claim. I had a list of potential diagnoses in mind. My first thought had been drugs, but given the result of the toxicology screen, that etiology was rather convincingly out. There was a remote chance that his symptoms were the result of exposure to some volatile substance in his metalwork, but the blood tests weren't indicative of any kind of dangerous solvent or heavy metal exposure. The other two options were either bipolar mania or a primary psychotic disorder like schizophrenia. In both of those conditions, medication would be the treatment of choice for an acute flare of symptoms like this one. Colin, thank you so much for sharing your thoughts with us, I said. I know you've felt misunderstood recently, so we're going to work very hard to understand what you're experiencing. This was true, but it was also an attempt to navigate the complexities of trying to treat someone exhibiting psychotic symptoms without reaching too far into paternalism or worse, trickery. Frequently, patients are reticent to take medication. Sometimes their reasons are good and sound ones. Sometimes their fears are paranoid, their beliefs illogical, or their minds simply cannot process the information fully enough to make an informed decision. I believed that medication could help Colin, and as a result, I tried to convince him to give it a try. I thought my best strategy was to talk to him about it in his own terms. We have some medicines that I think could help you communicate your experience more clearly. Colin looked at me quizzically. Why would I take medicine, he asked. I'm in love with the feeling I have right now. This joy is better than any drugs. And this is how our conversations went that morning and for the next few mornings. The nursing notes in the chart were similar from one shift to the next. Patient is pleasant, dreamy, and detached. He continues to pace on the unit or stand in place until redirected, refusing meds. A few days in, during our morning session, Colin began asking to leave. It's not that there isn't plenty to love in here, he said, gesturing toward a metal filing cabinet and then an institutional plastic chair, but I'm not sure how much longer this place needs me. It's easy in a situation such as Colin's to regard the institution of psychiatry as an authoritarian legacy of One Flew Over the Cuckoo's Nest. To think of psychiatrists as cartoonish egomaniacs who thrive on their ability to take away the agency of others or who leave no room for divinity or difference. Indeed, many patients who are admitted to my care reveal deep-seated fears that they will be stripped of their rights, medicated against their will, restrained, or sedated into the Thorazine shuffle. It may be tempting to lament the hospitalization of a patient with a heightened sense of connectedness and a new spiritual fervor. Indeed, Colin's case was even more ambiguous because he seemed to be more elated than distressed. Yet the costs and dangers associated with psychosis are tragically real. The famed author and neurologist Oliver Sacks points out the perilous allure of madness in discussing what he calls euphoric hyperstates, or states of ominous extravagance. Sacks cautions us against ignoring, or worse, celebrating symptoms that seem to be happy but are a departure from a person's typical self. The paradox of an illness which can present as wellness, as a wonderful feeling of health and well-being, and only later reveal its malignant potentials, is one of the chimeras, tricks, and ironies of nature. In fact, a heightened good feeling, what George Eliot evocatively called dangerous wellness, can itself be a signal of sickness to come, more terrible still for its deception. Most of us cannot exist over time in a sustained state of exaltation. More often, a high is a sign of a crash to come. Many of the healthiest among us are familiar with that truth. For the mentally ill, the danger can be even more pronounced. The poet Robert Lowell, who endured both the excoriating manias and the debilitating depressions of bipolar illness, wrote, "If we see a light at the end of the tunnel, it's the light of an oncoming train." I was a poet before I was a medical student, so I love the opportunity to throw poetry into medical writing. So I like Lowell being there, and I have a little bit of Theodore Recky that I'm going to read here, included in this portion. And this section we'll talk a little bit about the idea of abiding, which Marcia alluded to at the beginning. So one of the chapters in the book is about psychogenic seizures, so non-epileptic seizures, seizures that look every bit like an epileptic seizure, but in fact there's no brain activity that reflects this. These are physical manifestations of psychological symptoms. And at Brown, we're very fortunate to have one of the world's preeminent thinkers about psychogenic seizures, Kurt LaFrance, who is an esteemed clinician and a friend of mine now. But I went to him when I was writing this chapter, and I thought, he's going to really teach me the cutting-edge stuff about psychogenic seizures, and he's going to really help me discern between an epileptic seizure and a psychogenic seizure, which it turns out is essentially impossible to do without video EEG. But I went in with these high hopes that he's one of the great thinkers and he's going to really teach me about how to give care to these patients. And he absolutely did teach me about how to give care to them, but he did so in talking to me about this tenet of abiding with patients. And he talks about the word abide, which actually has a biblical origin. And it dates back to 1120. And the definition of it reads like this beautiful mantra of fidelity or recitation of devotion. So to remain with, to hold to, remain true to endure, stand firm or sure, to wait till the end of, hear through, to await defiantly, to face. So all of these things that Kurt LaFrance was saying, when you join a patient on their journey of illness, these are the things that their physician should do. We should abide with our patients. We should join with them in this way, to encounter, withstand, or sustain, to suffer, to bear, to undergo. So this conversation with Dr. LaFrance really changed my sense of how to treat my patients. And so there's reference in this section to abiding, and now you'll understand that thematic through line. The poet Theodore Recky endured episodes of severe depression throughout his life. His poem, In a Dark Time, reads in part, "What's madness but nobility of soul at odds with circumstance? The day's on fire. I know the purity of pure despair, my shadow pinned against a sweating wall. That place among the rocks, is it a cave or winding path? The edge is what I have." As a psychiatrist, I hear the stories my patients tell me, noble souls that they are, and learn how their circumstances are at odds with their lives. They come to me bruised and upended, and when they do, the trajectories of their lives seem to them to be at best uncertain, at worst doomed. To fear that you might kill your own child, to scour your face with sandpaper, to swallow bed springs. This is the purity of pure despair. If I am to abide with these patients, then I must accompany them to that place among the rocks, to the sweating wall. I must face with them the uncertainty of what lies beyond. I must stand at the edge with them and peer over into the fathomless depths. If I tell my patients, as I do, that this life can be a tolerable one, that they can face their fears and their traumas, their visions and voices, their misery, then I must look at what I am asking them to endure, and I must look at it full in the face. The French philosopher and Christian mystic Simone Weil wrote that to understand affliction, one must accept our total human vulnerability. I may lose at any moment, she wrote, through the play of circumstance over which I have no control, anything whatsoever I possess, including those things which are so intimately mine that I consider them as being myself. Standing on the edge with my patients, abiding with them, means that I must harbor a true awareness that I too could lose my child through the play of circumstance over which I have no control. I could lose my home, my financial security, my safety. I could lose my mind. Any of us could. A wonderful psychotherapist said to me in the wake of my having learned of my mother's breast cancer that we all live beneath a veil of invulnerability. For the most part, we act as if we and our loved ones will live forever, and then there are earth-shattering moments in our lives, a diagnosis, an accident, some unforeseen catastrophe, when the veil is pulled back and we see with clarity that we are all, in fact, perched upon a precipice. Mental illness pierces the veil, and those who suffer from it dwell with their fragility in plain view. My role as a psychiatrist is not to try to repair the veil, but to strengthen my patients so that they can live, so that they can suffer less, so that they can hope. Mary Weatherston is a psychologist who lives in Michigan. She is also a dear friend of mine. More than a decade ago, when I was trying to decide whether to go to medical school to become a psychiatrist, I called her to talk with her about her practice. I worried, I told her, about what it would be like to deal with my patients' misery day in and day out. In retrospect, I think I was asking her how to abide with the suffering of others. Mary shares my love for northern Michigan and its lakes. Without thinking, she reached to that shared territory for a metaphor. The patients we work with have fallen through the ice in the middle of a frozen lake, she began. My job, your job, should you take this path, is to go out to them, to be with them on the thin ice, and to work to get them out of the frigid water. I listened as she continued, but you must know that if you go out to them on that thin ice, there's a real danger that you'll fall in too. So if you go into this work, you've got to be anchored to the shore. You can reach out one hand to the person in the water, she cautioned, but your other hand needs to have a firm grip on the people and things that connect you to the shore. If you don't, you lose the people who are your patients, and you lose yourself. I'm going to wrap up with a brief passage about one of my anchors to the shore. So my partner Deb was here giving a talk as a playwright a year or two ago, and so I chose this section because some of you in the audience have met her, and this is about a conversation that she and I had. For our 10th wedding anniversary, Deborah and I leave our children with a beloved babysitter and return to the Vermont inn where we were married. The 4-hour drive from our home, which might have been onerous before we had children, is now a blissful chance to catch up and gossip and pontificate. As I look out the window at hills and hills of trees sliding past us, their leaves beginning to break into the colors of flame, I find that I'm thinking about a question the psychiatrist and philosopher M.O.C. Drury posed about Joan of Arc. Supposing Robert de Baudricourt had been able to give Joan a stiff dose of phenothiazine instead of the panoply of a knight at arms, Drury asked, imagining that today the saint's holy visions might be treated with an antipsychotic. Would she have returned in peace to the sheep-herding at Domremy? What about Joan of Arc? I asked Deborah, sharing Drury's question with her as she drives. I mean, if I saw someone today with her exact story, message from God, mission to overthrow the government, the whole deal, I don't think there's any way I would come to any conclusion other than that she was psychiatrically ill. In fact, I add, I think the same can be said for a whole number of saints and martyrs who saw visions, or flagellated themselves, or fasted for prolonged periods of time. If I saw that today, I'd trail off. But if you saw someone with those symptoms today, Deborah says, and they seemed to you to be at risk or suffering, are you saying you think you'd be wrong to treat them? No, I say. I think I'd be right to treat them. But what does that mean? Does that mean that psychiatry leaves no room for divinity? That we'd medicate a person out of what could otherwise be a transformative and saintly life? That we'd subjugate or worse, block some message from God? Seriously? Deborah asks. What? I say. Seriously, you're worried that you are somehow blocking God's communication to the world? Now who's paranoid or grandiose or whatever you call it? It takes me a minute to see that she is not just teasing me, that she is also, as always, very wise. She is pointing out my overly narrow assumptions about the possibilities of divine experience. If there is a God, and you know I'm not sure about that, she continues, but if there is, don't you think that how God reaches us today would necessarily look different than it did in the 15th century? And that God would find a way to communicate his message that wasn't thwarted by your little pills? I start to grin. You mean Big Pharma can't kill God? Yes, she says, grinning with me. That's exactly what I mean. Stop there.
Thank you so much. And we have a generous amount of time for what Christine has said is one of her favorite parts of giving presentations, and that is conversation with those who've come to listen and to think. So we have a couple of microphones which we will bring to you for your comments and questions. And if her talk is any indication, she will answer them quite beautifully. So who would like to start? Yes. And please identify yourself when you have the mic.
Margaret Norman, from lately at the Center for Biomedical Ethics and in the Department of Religious Studies. Thank you. It's lovely. My question has to do with, writing about patients is always a fraught deal, right? Lots of questions and lots of different pronouncements about whether one should do that, and if so, how you go about it. And it's particularly fraught with psychiatric patients, isn't it? And I'd just like to hear your reflections on how you work through that question in order to write a book.
Yes, I'm so glad you asked, and this is a question this is the one question that has come up at every talk I've given, so I think it's a very important question, and it's one that I have weighed.
Would you mind repeating the question?
Oh, sure. The question was, writing about patients raises a lot of ethical questions and concerns, and writing about psychiatric patients in particular has some unique concerns. So I have given a great deal of thought to this over the years, and I don't think there's, as is true with most good questions, I don't think there's a simple answer to it. Psychology and psychiatry have a different relationship with this, because you also have to assess there's a difference in consenting a patient for this, whereas Jerome Groopman has a patient with an interesting heart condition. He talks to that patient about whether or not they'd like to be written about. It's a more straightforward discussion than one with a person who may or may not be in their right state of mind, a patient who perceives themselves to be in a relationship where they want to please their therapist or psychiatrist. So there's a power imbalance that I think is different. So psychology and psychiatry have treated this in two different ways. They've either gone with a model of consent or gone with a model of de-identification of patients. Sometimes people also write a composite, which I think raises other also difficult questions. But for the most part, what I have done is when it has not been possible or realistic or right to consent a patient, I've worked with a model of de-identification. And this question, though it's funny to admit, was one that I had not thought about at all before I wrote Body of Work, my first book, which was about the experience of dissenting a cadaver. And I was on an NPR Colin show, and the cadaver that I dissected with my table mates did not have an umbilicus. She had no belly button. And a big part of the book and Body of Work is about how that remained a mystery and how there's some things about the body that remain mysterious. So I was on an NPR Colin show, and a man said, my mother gave her body to Brown, and I had this moment where I thought, oh my gosh, and he's going to say, and she did not have an umbilicus. And it had never dawned on me that was an identifying detail about not one of my patients, but indeed about someone who was in my care, right? So since that moment, it's something that I've thought about, particularly in Rhode Island's a particularly small state. So I go through great pains to make sure that a patient would not be recognizable. I think there are those voices that say that these stories are not ours and that we shouldn't even write about them. What I see in contrast is a supreme kind of voicelessness in the patients with whom I work. That their experiences and their stories are not out in the world to the degree that I feel they should be. And I think if we're making healthcare and policy decisions all the time that make presumptions about the journeys of my patients. And so for me, there's also a cost in not writing these stories. I think that there's a particular view that we have as clinicians, and there's an advocacy role to be had, and there's something that diminishes the isolation that patients feel when they feel as though their story's out in the world. So it's a complicated question that deserves to be weighed, but in my mind, it's important to share these stories because they too often go unheard. Long answer. I promise all my answers won't be that long.
Someone else?
I have a question. So you said you de-identify them, but how would you go about de-identifying them without completely changing the story? Because I felt like the crucial part of Lauren's story, for example, was things that would identify her.
Yeah, the sad thing about a patient like Lauren is there are actually many patients who we see who have similar stories to that. So in fact, I wrote an op-ed piece for the New York Times, and it was all ready to go, all in press, based on Lauren, and they called and said, okay, we just need to make sure that Lauren isn't a pseudonym. And I said, Lauren's absolutely a pseudonym. And they said, well, we at the New York Times have a policy of not publishing false names, so we can't run this piece. This is 2 days before it's supposed to be in the Sunday Review this month. And I said, well, I absolutely will not. I'm not going to, this is written about under a pseudonym, absolutely not. And they said, okay, well, could you use her first initial? And I said, well, I can't because her first initial is different than L, and no. But I said, but I have another patient who is similar that I can write about and use that patient's initial. So I think we all feel as though these stories are so unique. And the reality is that there is a pattern to mental illness, and often the things that seem as though they would be the most identifiable because of their uniqueness are actually symptoms that we see frequently, and swallowing of inanimate objects is unfortunately one of those things.
In that same vein, I know that some physicians, and not necessarily psychiatrists, have shared what they have written about a person who's been their patient with that person before they have published it. What's your thought on that? Not that we're expecting that that's what you do.
I don't. I really, but for people who adopt a sort of scorched earth policy of writing where they don't care who it hurts, I don't really stand in judgment of the way that people make this decision, as long as I feel as though they're doing it from a place of respect and honor. And I think that there is a way in which that interaction itself can be a therapeutic interaction. So I think that idea is an interesting and compelling idea. It's not, what I find with my own writing is that I often don't realize that I want to write about a patient until months or years after I've seen that patient. I find that I'm still returning to that. So it's not a sort of in the moment thing, which I actually like because I don't really want to be in the moment with the patient thinking, oh, this is something I'd really like to write about. I want that time to be clinical time. Right. Yeah.
So I'm Mary Kate Marshall from the Center for Biomedical Ethics and Humanities. So your stories are also about your colleagues, and I just wonder how you navigate that course, because they seem quite real in your story, and you're forthright about our foibles and how humor plays into the clinical environment, and perhaps not so positive things. So I just wonder whether you can speak to that.
Yeah. Anyone that I name by name in any of my books, so colleague, friend, family member, I always, this goes back to my aversion to the scorched earth piece, I always give them a draft before it's published to make sure that it seems fair and right to them. And if there's anything in that that makes them uncomfortable or that makes them, or that they feel is unfair, I don't publish it. Simple as that. So I think that's, if you're going to name someone real in your books, I suppose there would be an instance where I was taking someone to task and I felt like it's important to do so, but I don't think I'd use the public forum. I don't think that would be my avenue. Yeah. Yes.
Hi, I'm Mary Lou. I'm a dietitian and a clinician, and although I think about you as who I aspire to be in terms of kind of having that ideal of I want to abide in my patients, and at the same time I identified with some of those people that you referred to as having repugnance. And although I'm a little bit ashamed, or very ashamed of kind of saying that, the reality is that it exists in all of us. So I guess I would just say, without the training of a psychiatrist and this kind of day-to-day clinician, how do we do that and still maintain that level of honesty within ourselves, but yet having this compassion that you beautifully possess?
I think that, what a nice question. And I think, I see a real value in repugnance. I think we really ought to pay attention to things that we have a strong reaction against. And I think I see it as an invitation to see what it's setting. I mean, this is the shrink in me, but I see it as an invitation to look at what is it that is resonating with me so strongly. So I think often for those of us who are type A overachieving physicians, we just have to work harder in order to score better on the tests, and then we have to work harder to get a good board score, and then we have to work harder, and suddenly there's a patient that no matter how hard you work, their cancer doesn't go away. Or no matter how hard you work, they continue to hurt themselves. And that, I think, makes us feel like failures. And we are not students of failure. We are students of achievement and shininess and hard work. And so I think there's a way in which we then externalize that feeling, that internal, like, uh-oh, I'm failing. I can't stop this cancer. We suddenly say, well, it's not working. His cancer is terminal. There's nothing more I can do. Let me focus my attention on a different patient. And suddenly we abandon our dying patient, saying there's nothing more we can do. When in fact, there's everything more that we can do. Continuing to stay with that patient as he dies is equally important to hammering him with the treatment regimen that can help him live. So I think when we suppress repugnance, it just grows and grows and grows and grows, and it comes out in less healthy ways. But I think taking a moment to say, why do I hate this patient? There are articles written that are interesting about hateful patients. Why do I hate this? Why do I dread these sessions with this patient? And what is it setting off in me that makes these interactions so uncomfortable? And I'm certainly guilty of it as well. I appreciate your kind description, but absolutely I have moments where I think, where I feel frustration, where I feel anger toward my patients, where I'm afraid of my patients sometimes. Absolutely. Those are human responses. We're dealing with human beings, and human beings can be difficult. So I think but I think we're more constructive when we look and see why our response is what it is.
Other comments, questions?
Wait, this is way up in the back.
Hi, so I'm Elizabeth. I'm actually from the English department, so I'm kind of
All right,
an oddball in the group. So forgive me if I'm asking about something that already happens in medical training. So I'm thinking about your narrative, and I'm sure that this is something that more doctors and nurses are starting to do. So how do you see these narratives playing into medical education for people that aspire to be doctors or nurses, or any sort of member of the medical profession?
Yeah. I think there's a real range of different kinds of medical narratives with different aims and different goals. I mean, I think that there are those that really intend to shape policy. There are those that intend to shape pedagogy. There are those that intend to just expose how hard it is to go through medical school and medical training. I think that every voice in this is an interesting and important voice. I mean, there has been a lot more writing by nurses recently, which I think is pretty fascinating also. I think the role in medical training is an evolving one. I think that schools like UVA have very serious intentions of picking the best of the medical literature and finding a way to enrich the medical curriculum with it. And then there are other schools that I think are just beginning to try to determine how to do that. So I think it remains to be seen. My hope is that there's also a section of this collection of writing that sort of bridges between medical writing and just literary writing and good writing, and I think that's where I really aspire to be, and I think there are others that land squarely in that territory, and I think that's as our culture becomes a culture that's much more educated about our own bodies, our own illnesses, our own medical decision making, I also think this is a place that has the potential to be a common space of conversation between doctors and non-doctors, and I think that's exciting.
Another question? We have time for maybe one more.
Hi, Eugene, retired psychiatrist. Your word abiding reminds me of Victoria's suite in Hotel God, slow healing.
Yeah, we were just talking about her. That's a book with a lot of good in it, and I think that idea is the same with Rose Beat.
The book is God's Hotel.
Yeah, it's wonderful.
She was here last November as a speaker. Although I think her program is not on YouTube, unfortunately. But the book is a good read.
Hi again, I'm Chris Peterson, OBGYN and Student Affairs. One of the things that, as I've gotten deeper into becoming a medical educator, I have wanted to do but have not done is to write about those experiences, and especially the one-on-ones with my students. And there's no literature on that other than the things we all know about, where a teacher writes about their student from the perspective of, aren't I heroic to have taken, this student from, a very deprived background into success. But there's no literature that I've been able to find that looks at the teacher-student relationship in the same way that medical narratives are looking at the doctor-patient relationship. And I'm, loath to do it publicly because, again, I don't want to, expose my students to, scrutiny. It's for me to understand the teacher-student relationship. But I'm wondering what your thoughts might be on the similarities and differences between those two relationships and writing about them.
So interesting. It's not a question I've thought about before, Chris, but I do think, the parallels that I think of immediately are, one of leadership but also sort of pairing together on a shared journey. And so I think that's a really interesting parallel. Yeah, it's not one that I've thought of before, but I think you should do it. I think for many of us in medicine, if you have those urges toward writing, even if it's not something that becomes public. I started writing as a first-year medical student body of work just as a kind of cathartic journal exercise. And I know, Marcia and I were talking about how sometimes those reflective writing sessions, conjure eye rolls and tedious. But that was very much for me feeling the urge of I need to make sense of this in some way. And then I thought, well, I'm going to make this into an article. I want to write an article for Rolling Stone or something about dissecting cadaver. And it turns out that it instead became this book project. But I think when you have paying attention to those urges of using writing as a way to make sense of something or illuminating something a relationship that has not been written about before, yes, you should. Yeah.
So all of you potential writers, you can start thinking about that. All you educators who haven't written. We're at the end of our hour. I will let you know that UVA Bookstore is outside the upstairs entrance with Christine Montross is falling into the fire. And she will be able to spend just a few minutes quickly before she has to head for a plane signing books. Again, I'd love to thank all of you for being here. Please join us next Wednesday when we have Gilbert Welch from Dartmouth talking about overdiagnosed, making people sick in pursuit of health. And we'll look forward to seeing you here. Thank you again.